Arthroscopic Autologous Iliac Crest bone grafting for augmentation glenoid bone loss, using suture anchor fixation, combined with remplissage procedure. The authors have no disclosures. The indication is massive glenoid bone loss and recurrent anterior instability. Big bone loss needing bony procedure in our clinic, accounting for 20%. The patient is positioned in the lateral decubitus position. The unicortical iliac crest graft is harvested from the ipsilateral side, starting 3 cm posterior to anterior superior iliac spine. The most commonly used graft is 8 to 10 mm in width, 25 mm in length, and 12 mm in height. Holes B and C, 3 mm below the glenoid fossa side. Hole B, 3 mm from the superior border. Hole C, 3 mm from the inferior border. Holes A1 and A2 to 6 mm below the glenoid fossa side. Hole A1 to 6 mm from the superior border. Hole A2 to 9 mm from the inferior border. A standard posterior portal is created for the insertion of the arthroscope. Anterior portal is placed in the rotator interval, just above the subscapularis tendon. Anterosuperior portal is placed behind the biceps tendon. Under visualization from the anterosuperior portal, when an off-track lesion is confirmed, 2 4.5 mm double-loaded suture anchors are placed at the superior and inferior margins of the central Hill-Sachs defect. Sutures from each anchor are passed and left untied for subsequent use. The middle glenohumeral ligament is routinely released from the glenoid neck. After complete release, the middle glenohumeral ligament is temporarily suture tensioned to the superior border of the subscapularis tendon. It increases the anterior capsular space. Under arthroscopic visualization from the posterior portal, a 3.0 mm double-loaded suture anchor is first implanted at the 5 o'clock position on the glenoid rim via the antero-inferior portal. Second 3.0 mm double-loaded anchor is then placed at the 3:30 position 5 mm below the glenoid surface via the anterior portal. For suture tails, from the 3:30 anchor pass through the A1 hole and A2 hole of bone graft respectively. The bone graft is delivered through the cannula and positioned to the glenoid neck. The first fixation is achieved by tying the mesh suture pair from the 3:30 anchor, using the A1 hole suture as the post to push the graft inferiorly during knot tying, providing initial stabilization. A strand of suture from the 5 o'clock anchor is retrieved through the cannula, guiding it through hole C using the pre-placed traction suture. The sutures from the 5 o'clock anchor were tied to secure the inferior margin of the bone block. The anchor at the 3 o'clock position is placed at the glenoid rim through the antero-inferior portal. One strand of suture from this anchor is then guided through hole B using the pre-placed traction suture. The sutures from the 3 o'clock anchor were tied to secure the superior margin of the bone. The final fixation is completed by tying the remaining suture from the 3:30 anchor while using the A2 hole suture as the post. Remove the provisional sutures, securing the subscapularis to the middle glenohumeral ligament. Last anchor is first implanted at the 4 o'clock position on the glenoid rim via the antero-inferior portal. The capsule labrum structure is pulled over the bone graft and attached to the glenoid bone strap using the remaining suture on the 5 o'clock anchor. The 2 sutures of the 4 o'clock anchor were used to repair and secure the medial glenohumeral ligament. Secure the medial glenohumeral ligament with the remaining suture of the 3 o'clock anchor. Bank cart repair is completed. The bone graft is kept outside the joint, forming a backup to the repaired capsule labrum structure. The sutures from the 2 posterior anchors for the Hill-Sachs lesion were tied using the double pulley technique, thereby completing the remplissage procedure.